Mr. Chairman, ladies and gentlemen, thank you very much for being invited to be here. I'd like to speak upon a topic which is perhaps a little bit out of the mainstream, namely a new access for nodes. Of course, the hype has disappeared a little bit with nodes. Nevertheless, I'm personally very much convinced that in, let's say, 5 to 10 years, we will actually be able to apply it in clinical routine. All of you know the barriers which have been defined about 5 years ago. If we look onto this list, even the access to the peritoneal cavity has not yet been completely resolved or managed, but of course we got a step ahead. The transsigmoidal or transanal access is something like a paria among the different possibilities. You know, the majority prefers the stomach. However, it's quite clear that the access from below has at least 3 important advantages. We can control, we can check the entry point directly. We have comparatively big space, and many regions of the abdomen can be easily better reached from the anus than from the esophagus or stomach. The first attempts to use the transrectal approach were unsuccessful. The number of inflammative complications was, of course, by far too high. So a lot of different groups set out to solve the problem in a different way. Perhaps this is a chance to introduce briefly our group in Munich, which is devoted to the development of nodes. It's remarkable insofar as we are a unit, an institution, with surgeons, gastroenterologists, and quite a number of engineers working together to solve the clinical problem. This is the group here in our OR facility. And the idea was, and the same ideas had many other authors on the world as well, to take TEM, the TEM device, as a platform to improve the transanal access for nodes. We started TEM with a slightly modified system or instrumentation set. In 1993, the ideas at that time was that in contrast to the original Buis device, we could simplify the new TEM device, since due to the arrival of minimally invasive surgery and laparoscopic instrumentation, we were convinced that we did not need any longer the highly sophisticated instruments of the original instruments. So this was the so-called TO device, developed at that time and later on commercially available. And this system was now modified in a way to use it for the transanal access for nodes. This is the whole system here. And if you look at it closely, then you see the different components. This is the tube, the main tube, but the bevel is in another direction. You see 2 different caps, and on the left side, the specially curved trocar to introduce the endoscope into the abdominal cavity in a sterile way. And now, looking onto the procedure itself, it starts with the creation of a hydroperitoneum. That is to say, we installate about 2 liters of tauroline into the abdominal cavity via a Veress needle. And what is the purpose of it? It's shown here schematically. As soon as we installate the fluid into the, sorry for this problem, but nevertheless, I think you will understand what the idea is. If we position the patient into the anti-Trendelenburg position, then a rectocele will be created, and this rectocele can be used to enter the abdomen without danger. And this works it works in pigs as well as in humans. Of course, we tried it out. Using the tube of the ISA device, we can produce reliably this rectocele. And if you are then performing endoscopic ultrasound, you can clearly identify the site where you can perform your puncture and where you can introduce a guide wire into the abdominal cavity without the danger of performing any lesion to the bowel. This works quite reliably, and as soon as you have identified the most suitable site, you can place a purse string suture, which can be easily done via the TEM approach. Then you do the purse string, you position the purse string suture, and within this area and via the guide wire, you may now introduce this curved trocar. And then I think it's quite obvious how we go on. We remove the obturator, and then the flexible endoscope is introduced. We have, of course, valves here. We can insufflate the gas and so on. And you can do your Knowles procedure without contaminating the abdominal cavity, since the interior of the trocar is sterile. And the last decisive step is, of course, to occlude the entry point, which is a critical moment or point. First of all, we close the suture, the purse string suture, and then this nipple, which is created by the closure of the purse string suture, is cut off using a linear stapler. The last couple of months, we often use the Ovesco device as well, which is even more practical, but a little bit more expensive. Of course, we checked, or we evaluated this procedure in animal studies, performed, first of all, normal Knowles peritonoscopy, and after 10 days, we had a look onto the entry site of the animals who had been sacrificed. And as all of you see here, the results were highly satisfying, as could be expected after the application of a linear stapler. And even after only 10 days, healing was complete, and many of the clips had already vanished. In none of the animals we had any signs of inflammation. And this is the histopathological finding. You see, the effect is quite okay. So then we started survival studies under practical conditions. In a hybrid technique, we removed via Knowles the gallbladder. Well-known procedure, but this is the transrectal, transsigmoidal excision of the gallbladder. All of you have already seen some videos of notes operations and even performed them for yourself. So I think we do not care here for the video because of those technical problems. Sorry for that. It doesn't. No. Okay. Okay. At any rate, to conclude, we were able to perform on a regular basis in this quite a series of animals to perform cholecystectomy, and we could show that this could be performed without major complications, in particular without inflammatory complications. And as shown here, and the more you get accustomed to the technique, the more, the better the results and the faster the operation. So the next important thing now to prove that this new approach is really reliable in regards to the prevention of inflammation, we decided to check whether it is possible to implant an artificial prosthesis into the abdominal cavity via the rectum. I think all of you will concede that implanting a foreign body is quite a test. So, just as an example, we had developed in other studies this new ring for the treatment of reflux disease. I don't know whether any of you reminds the former angel-chick prosthesis, which was good, which worked well, but which made a lot of problems because of the foreign body complications. This can be avoided by a new type of ring, and in this case here, we try to check whether this can be brought into the abdomen without contamination. So we performed this type of operation in a similar way as, for example, a cholecystectomy. It's, of course, a little bit more tricky. You have to reach the cardia. You have to bring a ring into the abdomen via the rectum, and then it has to be positioned around the cardia. This is technically feasible, although time-consuming, but it is can be done in a standardized way. I really apologize for that. In this video, you would see how we place the ring into the correct position around the esophagogastric junction. So, of course, we were very much interested in the results, and after 10 days, we performed. We sacrificed the animals, and as a matter of fact, we were successful in 7 out of 8 cases. In one case, we had a contamination, although not clinically apparent, but we had a complication. What had happened during the operation, there was a temporary dislocation of the trocar, so this could well explain why in this single case we had a contamination. In other words, we are now very confident that even via the rectum it is possible to enter the abdomen without problems, without without a high and a danger of contamination. This system was applied in cadavers successfully, even in very obese patients, in males without problems, And currently we are doing it. We are evaluating the approach in humans prior to anterior colonic resections. And hopefully the first applications in humans will be possible at the end of this year. We even got a step, went a step further. We are convinced now that the majority of pure nodes colorectal procedures will need more than just one major access. And the question is now, what should we do in case of male patients? In female patients, it's easy. You can use the vagina. What to do in male patients? And so we systematically checked the possibility to enter the abdomen via the bladder as well. And as a matter of fact, we performed a series of patients of transurethral approaches and dilated the sphincter up to 36 French diameter. That of course we are content under normal conditions with only 5 millimeters, but in this case it was a little bit more. It was, let's say, exaggerated. This is the look onto the bladder via the ISA approach. This is the trocar, the curved trocar, and this is the endoscope. Now the bladder is entered, and under visual control, it's really trivial to find the entrance point. As soon as you have found the correct spot, you can perforate it via a guide wire. This is now a look onto the bladder, and I think you can imagine it's not difficult to find now the right spot to enter the abdomen. And as soon as you have perforated, you can dilate this entrance point, and finally an additional endoscope or an instrument can be introduced into the abdomen. And from now on, you can work with 2 hands, which makes the maneuvers by far more easy. Of course, this was systematically checked whether the sphincter would tolerate, the sphincter and the urethra would tolerate this dilatation using a specially designed Bouginard set. But actually, we did not have major problems with the sphincter. Then we, in addition, checked whether the transanal approach is really useful to perform colorectal surgery. And after this systematic comparison of the transgastric and the transcolonic approach, we are now convinced that especially for colorectal complex colorectal operation surgeries, the trans-sigmoid approach is the best one. I started when I pointed out that the transanal or transrectal approach was considered a paria, something very exotic in the beginning of nodes. Obviously, this changed in the last couple of years, and more groups are convinced that the transrectal approach is a good chance, a good possibility to perform colorectal procedures. And if you look back into the beginning, we proposed the ISA procedure back in 2007, we are happy about the fact that the main components of the ISA approach are now evaluated in detail and supported by other groups as well. The idea of the hydroperitoneum, obviously, it was accepted. The majority of groups, I think, are convinced that using a platform is helpful. In addition, it became clear that we need one or the other way of a special closure technique. And finally, I think the majority is now confirmed that we need a trocar, an additional trocar, if we enter the abdomen via the rectum. And so far, I think the ISA approach is mature now for clinical application, and we will start, of course, with colorectal procedure. What is not mentioned here is that we already could find out or show that machines like the spider or semi-rigid manipulating platforms can be introduced via the rectum. This is the only approach where it is possible to use, for example, the spider if you don't want to use the navel. And so far, I think it's a promising experimental approach. Perhaps in 1 year, we will be able to report the first clinical results. Thank you very much for your interest.